to this last session of the day, concurrent session on evolving strategies in drug treatment. I'm Annette Verster. I work at the World Health Organization in Geneva, and I lead the work on key populations, including people who use drugs, drug policy, reform, harm reduction, etc. It's an honor to be here and to be chairing this session. I'm very aware that this is a difficult time of the day, and that at least for me, some brain fog is setting in. So really appreciate your attendance here. Just want to say that this session is live streamed, so we all have to use the microphone so that people can online can fully participate. And we will also be at the end maybe getting questions from people who are joining online. So we have 4 speakers going from the United States to Australia to Ukraine to Canada, and all talking about different aspects and new ideas with regard to the treatment of drug dependence. Our first speaker is Mary Figgatt. Did I say that correctly? Yes? Yeah. Okay. Sorry, I just have to, of course, now things don't work. Mary is a postdoctoral fellow at Brown University in Rhode Island, United States. She's an epidemiologist who focuses on understanding and improving care for people who use drugs with wounds and bacterial infections, as well as their access to opioid agonist treatment. Mary, the floor is yours. You've got around 15 minutes, and as I said, the questions will come right at the end of the session.
Hi, everyone. Thank you for coming today. I'm really excited to talk to you. So today I'm going to be talking a little bit about some work we've been doing in part of the U.S. that's in the Northeast, in the very small state of Rhode Island. And I'll be talking a little bit about how kind of in the era of fentanyl, we've seen some changes in people's experience with opioid agonist treatment. Oh, that did work. Okay, great. I have no disclosures, and I do want to acknowledge our funders, which are currently the National Institutes of Health. And the views are definitely ours and not theirs, so. So in the United States, like in a lot of other places of the world, we've been seeing a massive shift in the drug supply. And, you know, while we commonly talk about fentanyl, there's a lot more that's going on. And at the same time, we've also, there's been some changes, some good and some not so great in the access that people have to opioid agonist treatment. And so we really rely on methadone and buprenorphine in the US. Methadone is heavily regulated. Most times people have to go into a clinic in person daily and pick up their doses while they're being supervised and monitored. Buprenorphine has become way more accessible. So there's been a lot of efforts to make this more available through prescribers in the US, where now it's kind of expanded, where they used to have to get certain permissions to prescribe buprenorphine, but now that's kind of widened ever since the pandemic. So that's been great, but we really haven't seen that there's been a major shift in uptake of OAT, specifically in Rhode Island. So these data are representing, I pulled this off of a colleague's website, by the way, this is not my own. But yeah, we've just kind of seen this plateau in uptake and almost like a little downturn. And that kind of leads to some things that we've been hearing in the community, is that a lot of people have been reporting that they've been experiencing more precipitated withdrawal when they're starting buprenorphine in particular. And so precipitated withdrawal is when someone experiences a rapid onset of very intense withdrawal symptoms that is caused by some sort of medication that immediately sends someone into withdrawal. And so the reason why we believe this is happening is because fentanyl binds so tightly, and buprenorphine will just knock it off the receptors. And then also fentanyl stays within fat tissues. So even if someone has not had fentanyl for a little while, it might still come out. And so precipitated withdrawal can happen. And so some of the strategies that are being tested pretty regularly to try and reduce this is micro-induction of buprenorphine. So it's when people cut up buprenorphine strips into small doses and incrementally increase their dose until they get to that dose that's good for them. So that's one thing, but I will say that precipitated withdrawal is possibly just one explanation for some of these shifts. So while I'll be talking about that, there's a lot of others that we should consider as well. So some of the gaps in the research currently is that there's a lot of evidence coming out right now about people's experience with precipitated withdrawal, but a lot of the research has been kind of in more of these clinical settings where people are potentially hospitalized, and then it's monitored on a regular basis by a doctor, and they come in, check on them every hour, and record their symptoms. So it's not the person themselves reporting the symptoms and how that experience has been for them, and that's also not representing what might be happening when someone takes it outside of these settings. So if they pick it up at a pharmacy, obtain it from other sources, and then try to start buprenorphine kind of on their own. And so what we wanted to do was really to understand how people who use unregulated fentanyl and other opioids are experiencing precipitated withdrawal while starting OAT, and in what kind of context. So the data in this presentation is from a study that's in Rhode Island, which is the Community Use and Testing Study. This is a observational cohort study of people who are using harm reduction services in Rhode Island. It's people who use drugs, and they submit samples for drug checking. And so this includes someone bringing in a small sample of whatever they choose. It gets tested on site, and then it also gets sent out for further laboratory testing so we can look into kind of some of the potentially newer substances that are appearing on the market. And people also complete surveys every 6 months that asks them, just a little bit about their background, their experiences with treatment, and some of the other services that they use. And so these data right here are from, so in total, from the time we analyzed the survey, there were 196 people that were recruited into the survey, into the study, who had a history of unregulated fentanyl use. And among these people, the majority of people submitted samples that were suspected to be fentanyl or heroin. And people did submit other samples too, like cocaine. So these results are just for the samples that were suspected to be unregulated opioids. And so what we see is, by far, the large majority had fentanyl. That was not surprising for what we're dealing with. But we also see a lot of other stuff. So there's precursors of fentanyl, which just shows kind of, how much of the fentanyl has been synthesized in the drugs in that sample. We also saw some fentanyl analogs. Rarely saw heroin. And then about half of the samples had xylazine present, which is the veterinary sedative that's been causing some complications. And so overall, for the people that were included, many people had a history of accessing OAT, and but we do know that we did note that there's quite a difference in the percent of people that had experiences with buprenorphine versus methadone. And so a lot more people had, so about, I think, 3/4 had any sort of experience accessing methadone in the past, and about a half, if I'm doing the math right and seeing that correctly, had experiences with buprenorphine, but not a whole lot of people were currently using buprenorphine at the time of the study, and about a third were using methadone, or were on methadone. And so we asked everybody about if they had ever experienced precipitated withdrawal in their lifetime, and this was using a definition that was asking them, like, have you ever experienced really intense withdrawal symptoms that was very abnormal? So trying to distinguish this from kind of what people might have experienced as other sorts of withdrawal symptoms. And we described some of the symptoms as well. And we asked within what context did that occur. So was that while you're starting buprenorphine? Was that while you're starting methadone? Was it after receiving naloxone if someone had overdosed? So precipitated withdrawal was 7 times more common among those starting buprenorphine compared to methadone. And for the people that had experienced buprenorphine-associated precipitated withdrawal, about 2/3 had experienced it in kind of these settings outside of the hospital, so doing it on their own. And so then among people that had reported starting or trying to start buprenorphine in the past 6 months, we had asked them some specific questions about their experience. And about 3/4 had said they used a standard start, so as opposed to using kind of some of those micro-induction techniques. That means just using the dose that they were prescribed and going right into it. About half were doing it self-directed, so they were doing it kind of on their own. They were going through the process on their own. And 23% had experienced precipitated withdrawal during that specific episode within the last 6 months. So overall, I think there's a lot to learn and a lot that still needs to be done from this, but what we see is that precipitated withdrawal is occurring, and that's not necessarily breaking news, I think, but there's a lot that we need to do to try and reduce this, because if someone is interested in buprenorphine, we really got to make sure that what we're doing is providing them the easiest way as possible to get to actually start buprenorphine. So that can look like exploring some of these different induction methods, developing kind of better guidance for people, because some of the micro-induction techniques can be, there's a lot going on, and if you're feeling really horrible, it's not going to be super easy to follow these, like to keep up with these, like, making sure all your doses are there and everything like that. And also making sure that people have support strategies while they're inducting onto buprenorphine. And then also at the same time, because that might not be a good fit for everybody, we should make sure that we have access to other sorts of OAT. So in the environment in the United States where methadone is heavily regulated, we need to kind of be and are currently revisiting that to try and make sure that's more available to people. And then all of this in mind, within the context of fentanyl, the drug supply is changing yet again, and so there's different things like nitazines that are appearing on the market that we've started to see, and then some of these sedatives can really complicate OAT for people. So we need to understand and kind of respond really quickly to make sure that we're making sure that these treatments are effective for people who want to access them. And so you can look at either of these websites for a little bit more on these studies.
Thank you very much, Mary. Really interesting. And I wonder whether these results of where precipitated withdrawal is so much more common when using buprenorphine as compared to methadone, whether that could have an impact on the way methadone is prescribed versus buprenorphine, which methadone being so much more high threshold in the US, as far as I understand. So thanks very much. Our next speaker is Anna McVinish, and she's from Australia, and she's a specialist alcohol and drug nursing clinician who's worked in treatment, supervised consumption, and drug checking in Sydney, I think. With the sponsorship of a Churchill Fellowship, she recently investigated heroin and hydromorphine-assisted treatment models internationally. And this is what you're going to talk about. Thanks.
Thank you so much. I just need to start by saying how humbled I am to be here. Someone said, I think at the beginning, that it was a road show of heroes, and I think, honestly, I feel like I should, maybe I said this to Andrew, I should tie shoelaces in the corner and little else, but nonetheless, on the shoulders of giants and walking amongst them. Also wanted to acknowledge the traditional custodians here for Bogotá. I am grateful for my safe passage on country, and I'm honoured to be here. Also for those at home, the Gadigal of the Sydney Basin where I live and work. Their ongoing connection is to my benefit on a daily basis. And in honouring the struggle and generations thereof, I think, it requires acknowledgement that sovereignty hasn't been ceded. Let me go on. Oh, I should have said that bit when that slide was up. I apologise. This is an incredible Australian First Nations artist by the name of Tony Albert. Should anybody like to look him up? Big fan of his work. So in 2023, weirdly enough, I was with the sponsorship of the Churchill Trust, the Australian branch, with money bequeathed to the trust by Dr. Dorothea Sanders, an advocate for female innovation in science, her and her partner in life, who was also a nurse, was a nurse, bequeathed this money, and I was the incredibly fortunate recipient to travel with it to 13 heroin-assisted treatment sites internationally. And of course, no treatment exists in a vacuum, and so many of the kind of adjunct and surrounding harm reduction treatment services, thought leaders, activists, people in the community, obviously people accessing the services themselves and clinicians, to give context and depth. I visited Germany, Switzerland, Scotland, England and Norway, and British Columbia and Canada to learn about it, given that it's highly effective and yet barrier-laden as a treatment approach. And why did I do this? I'd been the implementing nurse clinical lead for Australia's first trial of the modality, where we trialled, obviously, injectable hydromorphone for opioid use disorder. And I was absolutely preoccupied, veritably plagued with the how. You know, the focus is so frequently on the kind of pharmacotherapeutics, and then to think about how do we implement it? How do we mobilize it? Like how do we make it meaningful for people? How do we make it sing? You know, and not just now, but over time. Because we'd seen remarkable things, because it was at once all about the drug and then yet hardly about it at all. Because also in the absence of consensus guidelines, I was confident that staff and participants in programs internationally would know what worked, you know, on the ground. But also to honour the contributions of our participants, because they had literally gifted, you know, for our experiment, their time and their privacy and their bodily autonomy to science in an effort to build knowledge to benefit the community. And so us being the first time in Australia, not the best time, felt a mandate, an imperative reciprocal gesture to go and learn. Here's a table. I'm sorry it got a little bit screwy in the translation. I'm actually not going to focus on data like this today. One of the outputs of the report of the project, of the investigation, is a report that I'll continue to progress. As you can see, there's kind of various categories here, and this is the barest bones summary. There are some errors, actually. My colleague Tori corrected today for me, for example, in Norway, oral tablet form diamorphine is also available. I put the star next to Australia because the treatment has since been discontinued. So instead of emphasising these kinds of treatment, actually I should acknowledge the report is also slow going and slower going than I hoped because of how challenging it was. It was 9 weeks of intimate storytelling, of people talking about their lives, the kind of calibre and quality of their experiences, death, their disappointments, it's been so challenging that I've needed to stop actually the last months, and it will come. And if anyone's interested, please reach out, and I'm looking forward to the opportunity to disseminate it, but it required quiet and not rushing because of the sensitivity and gravity. I had overall expected something relatively systematic in travelling, but instead it was incredibly contextual, highly subjective, and full of contradictions. And for all of the similarities you might recognise in these kind of basic metrics, there are equally many differences. And just like the treatment itself, the benefits can't be isolated as distinct from the qualities of the setting, nor from the qualities of the people delivering it. And so there's no kind of goodies versus baddies type evaluation that was going to adequately represent these complexities or the contextual pressures relevant for each site, and would also have risked diminishing the goodwill and curiosity of a number of, excellent teams motivated to innovate, and to learn and advance choice. And so while I sit here and raise a right eyebrow to HAT, heroin-assisted treatment in particular, being an emerging treatment, no treatment, I would say, is emerging with 30 years of high-quality data demonstrating its efficacy. And not just efficacy, but resounding treatment success. I also need to acknowledge the complex legal, regulatory and stigma-centric conversations, but barriers that have plagued that emergence. So I'm going to speak to a couple of fast facts and the value of HAT, despite some incongruence. Skipping ahead, this is a collection of images of a clinic that I visited in Zurich, for example, some varying medication formulations. You can see on the kind of top up here, Abgabe, like dispensary for arriving at the clinic, press the top button if you're having orals, bottom button if you're having injectable or intranasal diamorphine administration. It's all very simple and clear, but it is possible. This is possible, and that was an important takeaway. Also, I suppose, just having a look here. I also want to mention, this is relevant, though not about diamorphine. And again, another broader theme here that caused me to ask many questions about conventional modalities and how they're delivered in general and what the overall kind of system is constructed to be. That medications are engineered, important to acknowledge, they're engineered for surveillance. So in Australia, for example, there's liquid methadone and tablet methadone, Biceptone tablets are typically reserved for pain. However, that the majority of methadone was dispensed in tablet form, and nobody could tell me any kind of clinical reason why that was. It became clear, really, that it was for diversion management, essentially, that actually we could give tablets, but supervising people ingesting syrups performed an ulterior agenda. Also the utility of the drug effect, having the flexibility to take away doses here, that's what this is in this lunchbox, for example, is a takeaway drawn up in syringes of diamorphine ready to go. Yeah, okay. There's so much to say. This has been the ultimate challenge to kind of know what to share and what not to. This is another clinic that I visited, which I thought was important to mention, because people need to feel safe before they can be sick, and I think that's true for everybody, and so this is an example where environmental design had been paramount. People had put a lot of emphasis on not exposure, as it might seem, but it's especially important, and I've got here, and I need to come back to my notes because I wander, but when interfacing with treatment sites that have long held power and dealt in institutional violence and stigma, it's especially important. And so this design is not long lines of vision for monitoring or surveillance, more transparency and the absence of barriers, and that was made very explicit by the people there. There was some reluctance in installing what you might be able to see as small kind of glass kind of person framing barriers when COVID happened. But otherwise, it communicated trust and it communicated transparency and goodwill. Of course, again, there's so many stories we could go on, but requiring, again, acknowledgement. Each context is bound by the subjectivities of how clinical, regulatory and professional frameworks come together and where they intersect. And it's a fool's errand to make perfect the enemy of good, but understanding how they work and how we optimize within those is paramount. And safe to fail experiments of how can one kind of change what we are implicitly communicating held such value, because often the incongruence is overwhelming. There was an example speaking to a prescriber in Canada who retold that with drug checking having become available, there was a way of acknowledging this kind of average fentanyl content per street point of down. That in particular kind of participants that might be using kind of 2 to 3 points daily, there is no way within the framework for prescribing that that need could be met. There is no way. And with that requires the kind of further thought that they're overdosing somebody or over-sedation is an impossibility, in fact. And yet that prescribing models are bound by regulations ahead of need is, again, so obvious and yet so frequently overlooked, I find. Another example made by a pushback from somebody working in this space was kind of like, well, if you were severely alcohol dependent, would you possibly rightly consider that coming to me and me writing you a prescription for 2 litres of vodka and then expecting you to sit and drink it in my office is going to lead you to the best possible outcomes? And I say no. Like, we know that kind of, and again, this is stuff that we know, but not like know in our bones, but also frequently omit from clinical design, from model development. There's a lot. And so the question that I suppose was most common between sites was this kind of heroin-assisted treatment or hydromorphone-assisted treatment. What is it assisting in the first place? What does that mean? And in whose service is it? Because I don't know any clinicians, even those that might err in their approach over time, once off, the people, we've all met them, who goes to work in service of regulators, and being reminded of kind of the purpose driving this work, really, and centering on the kind of lived experience and needs expressed instead of allowing a medication to determine a treatment plan, to start with what people need and make a conclusion as to which is the best appropriate medication. I might skip this because I'm conscious of time. 1 minute. Okay, I am going to go ahead. This was a comment about a spectrum of approach that I observed between people who were sick and a kind of pathologizing approach, however supportive in many ways, versus the approach that led towards a kind of enfranchised citizenship, and again, within the context of individual pressures and forces relevant to each site, both existed. Again, an acknowledgement that we ask the most of people who are at most risk. I mean, this is a model that says that those whose needs have been least well met by what we have as established choices, who are at the most kind of acute risk of drug-related harm, and yet we ask the most of them in terms of how onerous we make treatment engagement expectations and compliance measures. That is incongruent, and acknowledging that as a kind of point to move forward with, I think, is key. Because, and I'll summarize now, this picture says enough. I think the clue is that we can think up the best models in the world, but the horse won't drink if the water's poison, And I think here is enough. I think often with the best of intentions, we may support people with the best that we know, and with that with which we feel most familiar. But it doesn't work to then say, to limit, I suppose, to say, with the soft stigma of low expectations, determine that someone is least capable of meeting their own needs, least able to be trusted around medications such as these, and yet expect great things without resourcing in an adaptive and person-centered way, And so that's, again, basically it, a very simple visual summary. I have to credit Vandu for cops out of healthcare. And also that HAT is actually a living harm reduction strategy, reducing the harms of treatment settings. And so without it, it's, treatment settings can replicate all of the harm that exists in with conventional modalities. And yet we can choose, and in fact choose for conventional modalities to go forward with a HAT approach, because the intimacy that became apparent when people became three-dimensional to one another in our setting was overwhelming. It strikes to my heart to this day, and it's not right for everybody, but knowing that is the key, right? Asking about it and stopping to listen. I also need to acknowledge that I'm but a bridge. This is the work of others. I had the most incredibly generous sharing of all of the people that I visited, the most open and supportive curiosity about my work and willingness to support it. I am yet but a humble servant of these people and many, many others. Thank you very much.
Thanks so much, Anna. I'm sure there will be lots of questions afterwards. Our third speaker is, that's correct, right? Yeah. is Yevheniia Zakrevska from Ukraine. She's Senior Manager of Opioid Agonist Therapy Projects at the Alliance of Public Health. And this organization engages in harm reduction projects and comprehensive support for people who use drugs. You have also 15 minutes, and you're going to talk about comprehensive gender-sensitive support to women who use drugs.
Hello, everyone. My name is Yevheniia Zakrevska, and I'm from the Alliance for Public Health in Ukraine. And it's my first harm reduction conference, and it's a big honor for me to be here today with you. So I want to talk today about how we implement gender-sensitive harm reduction services to women who use drugs, especially those who own opioid agonist therapy in context of war in Ukraine. So the title of our project is Comprehensive Gender-Sensitive Support to Women Who Use Drugs, and we implemented it with support of Expertise France and in partnership with Frontline AIDS and Ukrainian Network of Women Who Use Drugs, VONA. It seems to me important to say a few words about situation in my country and general context. So maybe somebody doesn't know. So Ukraine, one of the biggest country in the Europe, and war in Ukraine has been going over the 3 years, causing humanitarian and economic disaster. The war deeply impacted on healthcare infrastructure in Ukraine, during the first 3 years of the war, nearly 2,000 healthcare facilities were damaged and more than 300 completely destroyed. War also forced migration of population within the country and abroad. More than 9 million people leave their home. War also increased poverty and reducing access to health services, increased cases of gender-based violence, and of course in this situation dramatically increased the needs of people who use drugs, especially women, and not just in treatment but also on psychosocial support and legal and humanitarian help. And next slide, please. Thank you. Opioid Agonist program in Ukraine has been implemented for over 21 years, and Alliance supporting this program for the very beginning. Estimate number of people who use opioid and mixed use is about 278,000 persons, and of them 20% were women. It's due to IBBS 2020s, and as of the end of 2024, we have 207 OET sites, state OET sites in Ukraine, and more than 22,000 people on the program, and just only 12.5% are women. Here in the slide, on the chart, you may see that prevalence among female OET patients is over 44%, and much higher than prevalence of HIV among men. However, the number of women on OET program has been decreasing dramatically over the last 3 years. So this reflects serious gender gap, and of course, war one of the crucial impact, but there are lots of different reasons. So women who use drugs face multiple overlapping barriers in accessing treatment and support. They are highly stigmatized by society, by medical professionals, and especially and even by their family and relatives. Also, one of the barriers is gender-based violence and human rights violations, punitive policies and child custody threats. Many women avoid male-dominated settings and hesitate to seek care, especially those who have experienced traumatic experience in healthcare system. Also, war has a high impact on mental health and reproductive health in Ukraine. Basically, 70% of population in Ukraine have some mental health problems. Also, traumatic experience during obstetric and gynecological care, post-prison reintegration, and one of barrier I would like to mention, our partners from NGO Yevheniia conducted a survey among women who use drugs about reason of treatment dropouts. And one of important barrier was inability to leave child unattended or discomfort of being with children while they're receiving treatment. So considering all above, we have tailored our project, which is gender sensitive, and we are providing comprehensive support. So we have opened, with the support experts in France, 5 mother and child rooms on OET sites in the biggest cities in Ukraine, in Kyiv, Dnipro, Lviv, Odessa, and Kryvyi Rih. And it became a comfortable, supportive space for women in all their diversity and women with their children. You may see a photo on slides of this room. So here in this room, our clients can receive complex range of different services, such like psychosocial support with enrollment to OET treatment, medical assistant. We are redirecting our clients to so-called friendly doctors, to gynecologists, dermatovenerologists, psychiatrists, pediatrician if needed. Also, we are providing screening and vaccination against human papillomavirus. I want to mention that it's first time in Ukraine when such services provide free for OIT patients, and we are providing the best vaccine, Gardasil. It's quite expensive, but we chose to provide best for our clients. Also, we are supporting reproductive health, age-sensitive support for elder women during menopause period, screening for mental health disorders and treatment, legal support, assistance with child custody issues, humanitarian support in form of certificates to supermarkets, screening for TB, assisted HIV STI testing, and screening of children's well-being. Here on the slide, you may see the map of Ukraine, and in every region, you may see the quantity of OIT patients, and those regions which are highlighted in pink, it's region where we are providing our work. So it's Lviv, Kyiv, and Odessa, and in Dnipro, there are 2 rooms in Dnipro and Kryvyi Rih. And about our goals and outcomes. Basically, our project officially launched on February 2024, but actually we start working from April. So during the first year of implementation of our project, we have made repair and equipment of 5 mother and child rooms, as I mentioned. It was quite challenging during considering context in Ukraine. And so 442 women became clients of our project, received complex services. 60 women started OIT, 86 got psychosocial support, 81% medical support, more than 2,000 social support consultations were provided, near 500 psychological, dermatovenerologist consultation, also pediatrician for children. We also provide free laboratory tests of sexual and reproductive health for our women and also on cancer markers. And they are in great demand. Some of our clients haven't visited, for example, gynecologists for several years, some for decades, because they have very traumatic experience in the past. But now our clients have a good connection with our doctors. They are not longer afraid of them and seek help and take care of their health. So this is a proof of concept that women do engage when services are accessible, trauma-informed, and not judgmental. Next slide. And about our plans and steps, future steps. So we see that our model works, and we plan, of course, to scale it up, expand to new OIT sites, maybe even to new region, if it will be possible. Strengthen cooperation with partner NGO, with state institutions. Also, we are planning to provide trainings for community representatives and peer leaders. Our partner from Frontline AIDS is contributing to integration of best gender practices and adaptation of approaches to wartime context. And this year, we will provide a range of trainings for community members. Also, we are providing informational campaign and to reduce stigma and raise awarenesses. Also, of course, exchange of experience, and we plan to scale in the model to national level, but of course it will take time, and we will see. And one of our main goals, of course, is encourage women to seek care, contributing there to improve health and well-being. Next slide. So on this slide, you may see the photos of our clients, of our social workers. We are proud that our clients trust us, and our rooms became a place of connection. It's not just treatment. So trust, peer support, and integrated care, that's what make it work. And next slide is also our clients, and usually they came with children. So it's a big honor for us that they believe, trust us, and we strive to do our best to improve services. And the last one, here is our team and our partners from NGO Yevheniia. You also may see QR code and get more information about our project. So thank you for listening. Thank you.
Thank you so much. That was wonderful. And I have to say, it's so impressive that what Ukraine is still managing to do and being innovative and setting up these new programs in the current situation of war. It's really humbling. Thank you. So our final speaker is Mohammad, Karamouzian. And Mohammad is a scientist at the Center on Drug Policy Evaluation in Toronto, and he is assistant professor at the University of Toronto's Public Health School. His research targets health inequities among marginalized populations, including sex workers, people who inject drugs, and the incarcerated, with a commitment to translating findings into impactful health policies. And I think your focus is your presentation is going to be on the patterns of use of biometric dispensing machine-based safer opioid supply in Vancouver. Mohammad, you have also 15 minutes, and here's the mic.
Thank you so much, and thanks to all the panelists. Great presentation so far. So I'm presenting this work on behalf of a group of colleagues. Actually, most of the work has been led by others. I'm just presenting as part of this work. And today I'll be talking about a model of safer supply prescription, which was implemented as part of the national scale-up of pilot projects dedicated to safer supply prescriptions only in BC. But before I begin, I'd like to acknowledge that the center that I work at is located on the land of many indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and Wendat people. And I also want to acknowledge that we're gathering on the ancestral land of Muisca people today. And we're grateful to be able to present for you on this land. I don't know if I have any disclosures, but shit comes up sometimes, but not that I know of. So I think like you've probably seen this presentation across the board. Canada, like many other settings, so predominantly North America and other settings in Europe, is dealing with a drug toxicity crisis. This is recent data, and I think it's up to September of 2024. And you see the number of deaths is just unbelievable, about 21 deaths per day. And initially, the overdose epidemic or the drug toxicity crisis was focused on the western side, but then it started going across the country. So it's a nationwide crisis. In response to this crisis, and in BC in particular, which is the first province that issued a public health emergency to get more resources dedicated to this public health emergency, they announced it in April 2016, and in response to that, and then after BC, other settings like Ontario and elsewhere, they also started highlighting the need for better interventions and scaling up interventions across the country. So there has been a scale up of many interventions, from interventions aimed at increasing access to treatment, take-home naloxone programs that have been scaled up, opioid prescription guidelines, opioid use disorder guidelines, clinical practice guidelines, and safer supply as an intervention that was aiming to engage with the drug supply, which I think is a big part of this crisis. And as you can see here, as part of the evaluation that I've been fortunate to lead nationally, 11 of these sites were being evaluated, but there are many more sites across the country, but only in Ontario and BC predominantly. And like there are like standalone programs here and there, but that's predominantly most of these interventions were, these programs were piloted in Ontario and BC. And in terms of like, what is a safer supply? And I don't know, like maybe some of the people have been in that in our previous panel with where there were like 2 presentations on safer supply. So this must be this may be redundant a bit, but to be very transparent about this, no one has a clear definition of a safer supply program. So what is a safer supply? And it means different things to different people. Some people include IOT as safer supply. Some people don't. They see that as treatment. They don't see safer supply as treatment. So there is no consensus there. But the first program of safer opioid supplies, which is focusing on unobserved take-home tablet opioids, that goes back to like a pilot project in London, Ontario in 2016. And after that, the concept of safer supply comes out of actually a peer-led document called the Safer Supply Concept Document that came out in 2019. So this was before the COVID pandemic. And then, but during the COVID pandemic, in BC in particular, there was something called the risk mitigation guidelines or prescribing patterns, which provided, as part of a COVID response metric, it provided take-home prescriptions for unobserved dosing of opioid stimulants and benzos. This program has been stopped like over a year now. So they moved on to safer prescribed alternatives or whatever they call. So, and there have been studies looking at the population level impact of what the BC risk mitigation prescribing did, and there's a B&J paper there that you can look up. So what I'm talking to you about today is a program that was part of the Safer Opioid Supply. And it's called MySafe. So the MySafe program is an innovative program because it tries to remove the barriers to engaging with healthcare providers, to reducing stigma, and providing flexibility of visits. As I noted with Safer Opioid Supplies, and as you might have heard throughout the conference, people are required to see their prescriber, get the prescription, and then get the medication on a daily basis, or sometimes there is some flexibility there, but they have to go somewhere within a defined period of time in terms of like hours of operations and stuff like that. But with the MySafe program, it's a biometric dispensing machine that's providing hydromorphone tablets, 8 milligrams each. That's what's available in market, but it's accessible 24/7 with a technology that was developed by a tech company, so a handprint scanner. And it was located in a couple of sites, including overdose prevention sites and some supportive housing settings. But what's important with the safer supply programs is that the way I understand them as an intervention is that the main outcome of interest is reducing overdoses and reducing people's reliance on a toxic drug supply. That's why it's an intervention that engages with the drug supply. But when people are accessing care, a lot of these safer opioid supply programs, they provide wraparound services. So they get better, like they're low threshold, they get access to social housing, they get access to supportive services for employment and all of that. So like overall, there would be improvement in other aspects of the client's lives. And this is something that I think like at this point, as we speak, there's been like 90 papers on safer supply, 100 papers on safer supply, different aspects of it. So there's a lot of evidence now since they started the programs. But with this particular study, what we were hoping to get a sense of was that when this program was initially established, one of the hypotheses was that, well, if we provide 24/7 access, then we would be reaching a group of people who don't want to go to a clinic at 9 a.m. because they have a job, or they want to go look for a job, and they want to access, they want to have the flexibility. And also, not every pharmacy provider is kind to people who use drugs in Vancouver. That's not news to people. But we wanted to see if this addresses that barrier, and also whether this is a model, one of the models that works for some people. And for this program, people would provide urine drug screening at baseline and follow up to get a sense of whether they are adhering to treatment or not. We can have a discussion about that. I think UDS in this context is not very accurate, and it's not really helpful to interpret the findings, but we'll talk about that if there's interest. So we looked at like about over 2 years of data. The data we had was from administrative records from the program. So we didn't do the surveys ourselves, but they were kind enough to share the data with us. So these were like baseline and follow-up surveys, in addition to and also qualitative urine drug screening. Qualitative meaning that it's a yes/no presence, and with hydromorphone, it's like max of up to last 72 hours, 48 hours, that the test is going to be positive, but it doesn't tell you how much is in the person's system, so it's not a really helpful intervention. But that was part of their protocol, and they had to implement it. We had nothing to do with that. And initially, they had like 96 people enrolled. They had follow-up data from the surveys for 66 people. And for people to be enrolled in that program, they had to self-report and do a urine drug test for fentanyl, self-report daily use of fentanyl, be interested in a medication like a tablet hydromorphone, and be at a high risk of overdose. And as you see here, they're like predominantly MAID, but predominantly socioeconomically marginalized, unemployed, unstable housing. About 1/3 were indigenous, which shows how overrepresented they are. And most of them had previous unsuccessful experiences with conventional OAT. And at baseline, there was a high prevalence of fentanyl on the day of the survey, methamphetamine, and self-reported history of overdose, recent overdose at baseline. When we looked at the number of visits made to the machine, it was over 13,000 visits. But what's interesting is that you can see that almost 80% of them were outside the typical pharmacy hours. And we got this data from the machine, so not from the surveys, but so these are very accurate. And from 5 p.m. to 11 p.m., which speaks to what the need that this model of care is providing for some people. Also, 1/3 of the visits were on weekends. Again, shows that when people are trying to have some stability in their lives, they need that flexibility. And then in terms of satisfaction, again, self-reported satisfaction was 100%, but the main reasons were around accessibility and convenience, reduced anxiety about withdrawal and cravings, and the fact that the machine does not judge. But in terms of self-reported outcomes, and this is an interesting finding, so they reported reduced use of unregulated opioids, reduced use of unregulated drugs, and decreased engagement with the street economy. But when you look at UDS, and that's why I was like, the findings can be misleading when you rely on a qualitative, cross-sectional UDS result. You may see that at baseline and follow-up, there wasn't much change. Again, it's a point in time. It doesn't negate the fact that people were using less, but they were still using. So their test would be positive. And why were they still using? Because as you've heard a lot throughout the conference, the dosages that are not meeting their needs, so they need to top that up, but they're still reducing their exposure to that toxic drug supply, and that's why overdose reduction was very significant. And in terms of benzodiazepine, again, I think it's a reflection of how the market in Canada and parts of US is getting like flooded with benzos. In terms of what they thought that the program could do better was, again, most of them thought that the dosage they were getting, like 14 to up to 28 milligram hydromorphones, that was not sufficient. Excuse me. And the dependence on a clinician buy-in, so you need a prescriber to be able to scale up these programs. Again, it's beyond the scope of the power that the programs have. And all of this, again, highlights that the need for flexible individual dosing strategies. In terms of technical challenges, again, this was a new machine developed by a tech company, so there would be glitches, and at the beginning of the implementation, this was more frequent, but they got better as things moved forward. In terms of limitations, like I said, the findings around the qualitative UDS tests they need to be interpreted cautiously. This was established like in a very few sites in BC, which has like a lot of, like a very different landscape when it comes to harm reduction. And like any other self-reported survey, there is potential for social desirability and recall biases. There is a number of qualitative studies led by my colleague, Dr. Bardwell, and Andrew Ifsens that I encourage you to look at. And these are all qualitative studies looking at implementation barriers, client experiences. Excuse me. And I think this is my last slide. So the take-home message is that this model of dispensation is an innovation in safer supply. Prescription, it's not the only model that safer supply should be provided for, but it does meet the needs of people, a special group of clients. And in terms of reducing the potential harms associated with unregulated drug use, this could be part of the response. Again, there are no silver bullets in that response, safer supply being one of the interventions. But at the end of the day, we need to engage with the drug supply one way or another. And in terms of continued optimization needed, there is a need for like making sure that there is flexibility around dosages and types of medications and technology options. Thanks so much for listening. Oh, sorry. There's no water.
Thank you so much, Mohammad. Well, very interesting 4 presentations with innovative forms of treatment, either in type of medication used for the treatment, as well as in the mode of delivery, from machines to mother and children rooms, and clinical settings. So we have some time for questions. Okay, thank you very much. So the sir in the blue shirt first. Can you please briefly also introduce yourself?
Hello. Ooh, loud. Hi, sorry, my name's Fraser. I am a drug advocate in the UK. I work at Release. I wanted to just... I'm so sorry, I've forgotten your name, the second panelist. Anna, thank you. So one of the interesting and sort of frustrating things about the UK is that we used to have take-home diamorphine prescribing, and in fact still do with some people who've managed to kind of hold on to it. There's also this very frustrating thing. So I work with someone as an advocate who is prescribed diamorphine, and he has a prescriber who is willing to prescribe it. That prescriber is reaching retirement age. when he retires, there is no one who can take it over because we no longer have the expertise. We no longer have that clinical experience. So he's very nervous about the future. And it seems that we've kind of lost this clinical knowledge. We've lost this culture of what was once called the British system in a very smug, patriotic way. And I'm also just thinking about what Mohammad said about sort of buy-in from clinicians. So this is a really an annoying question, because I guess I'm wondering if you have any thoughts on what we can do to change attitudes and cultures around this kind of prescribing, because it is, I think, for the people I know who are still on take-home diamorphine prescribing, it is the thing that works for them. It is the thing that allows them to live a life of stability and dignity. And it breaks my heart that there's not more of it. So sorry for this slightly rambly question, but if anyone has any thoughts, I would love to hear them.
Thank you very much. Let's take a few questions and then respond. Oh, very good. The lady in the back there first.
Hello, I'm Elisabeth Avril. I'm a GP from France, and I'm running an addiction center. And I have two questions. Well, it's a low threshold center. So we have around 1,000 patients every year, and they come, they just push the door, and they start whether what they want, methadone, buprenorphine, Suboxone, oral buprenorphine. And none of our patients never ask for Suboxone because they know that they are going to withdraw when they initiate the treatment. So I think it's Suboxone in the States, and it's not buprenorphine. And buprenorphine, it's possible, but Suboxone in France, it's not, the patients are not choosing this molecule because it doesn't suit their needs. And for the machine, I'm wondering why we have this program for 27 years now, so people are pushing the door, starting the treatment. More or less, it's really precarious people, vulnerable, and they are still consuming from the, but they can come when they want and have the dosage, and they can have high dosage, and we don't do urine tests, and we don't have overdose, and then we can refer people when they feel that they want to have the substitution for many days. We have another program so they can have twice a week, once a month, and we don't have fentanyl, of course, but we have heroin, and we have morphine sulfate also. So I think I wonder what is the need for a machine when people can do without judgment, and so you can how do you say in English? You can up as the dosage, and you can talk with them, and you can see them every day, and you can do social work and other things on centered to the person, not on their needs. So I'm wondering why.
Thank you. So why machines if you can also give take home? I guess that's the question. A third question? Yeah. Right.
Hi, this is a question for Mohammad. I'm Shelley Facenti, and I'm a public health consultant in the US and California, and I've been working with many different programs that provide OAT throughout California in different settings. And one thing I've never heard anyone raise is any kind of biometric access strategy. And I'm curious, I suspect that has never been raised because there's a lot of suspicion around having to have a registered handprint that would allow you to get access. And I imagine that would be a very large barrier for most of the places that I've worked with. So I'm curious, because that didn't come up as a barrier. Do you think that's because the people who are enrolled are people who already agreed to that? Or is that because it's not such an issue that you're finding? I'm curious about that. Thanks.
Thank you very much. How many more questions are there? 2. Shall we have a first round of responses, and then we come back to you? So we first start, otherwise we forget the questions. So the first question, well, maybe you want to start because it's, yeah.
Thank you so much, and thanks for the questions. I think first, like, why do we need machines? I think like when, okay, how do I put it? I think the perspective of a care provider in terms of how stigmatizing a service is very different than the perspective of a client. I might be thinking that I'm providing a very non-judgmental, flexible service, but the clients might disagree. But because there is a power imbalance there, you would never hear that from them, and they would never bring it up to you. I'm not saying that that's the case for you, but I'm just like putting this in context. So this particular service, I think it's not just about, well, they can come see the patient, see the clinic every day or not, but I think it's the autonomy that's different with this model of care. They can decide to go pick up their medication whenever the hell they want. Conventional clinical provision cannot offer that. And as you saw, like a lot of people were like after hours. I think that's one of the big things in terms of like this. And same thing applies, like I think like there isn't much innovation about this. Like people have been trying to put harm reduction in boxes and machines forever. Like condom distribution, needle syringe, dispensers, all of that. So same argument applies to that. Like why do you need an NSP within a machine where they can come to a pharmacy and ask for needles whenever they want? So I think like it's the additional barrier for people who just don't want to deal with a healthcare provider. Again, this is not a typical person with an opioid use disorder. This is someone who has tried OAT many, many times. And this is like the very marginalized, like I said, over 70% with recent or existing history of homelessness or unstable housing here and there. So I think like if I was in that position, I think I would think twice to see like, do I want to risk being traumatized again with recognizing that there are a lot of really good intentioned and amazing clinicians and providers that do provide non-stigmatizing service. But I think this is just one part of that reply, that response in terms of like people who have tried OAT, are failing, are still using a lot of fentanyl, have a really high prevalence of repeated overdoses, and are not willing to seek the care the typical way. But one thing with the machine is that you are still engaged with that, like with dosage conversations, all of those, with whatever, in terms of other services you need, you do meet a care provider on a regular basis. Those are the people who do the UDS, those are the people who complete these surveys, and they talk to you about dosages as well if you need to like make changes to their dosage. So I think like there is still an argument to make that there is a soft population within this group of marginalized people that would benefit from this. So I think like that was a longer response. Oh, the handprint. Yeah, I think like, well, I haven't been involved in like developing this intervention, so I'm not like everything I know is like hearsay from the conversations with the government who funded this pilot program. So I think like there are with safer supply programs, there are significant concerns around these programs flooding the market with hydromorphones and leading to a lot of diversion and promoting opioid initiation among opioid-naive youth in particular. So this was a real concern when they were like, so you are going to use what? Like you have to use something that ties this specific person to the machine. Otherwise, if it was a card, if it was a code, all of that could be used alternatively. Not to say that you can get your medication and sell it. So I don't think like that's a really strong argument, but that's as far as I know, and I can look into it if for you. But I think in terms of people who were registered in the program, they consented to this, so they knew that this would be one of the things. And in terms of the technological challenges that they faced, this was actually the handprint, because your hand had to be clean, and then so if they were coming out of like work and then the handprint was not really clean, so that the machine wouldn't work, and then they would go to withdrawal. So like it was in the middle of the night. So like there was a lot of those types of challenges, but they were really improved as they learned about the program more.
Thank you. And I don't know if anyone wanted to answer your point around prescribing. I think this issue around when we're talking about sustainability of programs, we come to primary care, obviously, and this goes for methadone, buprenorphine, and for other forms of treatment such as hydromorphone as well. So I don't know if any one of you would like to add to that, but
Hello. Also to commend your work, I know that you guys have fought tooth and nail to have prescriptions restored. Under the umbrella, you should be incredibly proud. It's noble work. I think in Britain, it's a particularly, and actually I don't like to use that word, Britain. In the United Kingdom, it's all tricky. It's a particularly confusing context, given that there are those kind of fragments remaining of the British model. There has also been, successful IOT programs that have then been defunded, and then there remains clinical use for the same chemical molecule. It's a particularly contingent, confusing scenario there. But I think remembering that what's useful out of the British model and taking it into the rest of the system, I think is something that I've thought of before, because actually what that is, I mean, imagine if methadone or buprenorphine was prescribed in the way that the British model had functioned, where you saw a doctor and you went home and you did it as you liked, I mean, we're not even there. And so destigmatizing diamorphine itself is also part of the work, understanding that pearl clutching doesn't help anyone in this instance, and it's actually just a medicine. And understanding that kind of medicine-focused approach. I think understanding as well kind of opioid use disorder management should include drug effect as part of its kind of intended efficacy, because I think without it, we fail to account for what the utility is and what's important to them. And thus, there's no scope to retain people in high reward, engaging, evidence-based treatment if we're pretending that it's something else. Meeting people's needs removes the need for people to go elsewhere. And this is particularly imperative now, given the risk of accessing the illicit supply. And I think it's time. Let's start high. Let's raise expectations and meet needs that will inhibit risk and ameliorate risk actually by giving people what they ask for. We have the agents.
Yeah, I don't really know the answer to your question, but I mean, I think like if there's one champion, that's great. I think, and like a champion clinician, that's great. I think it's, their job to pass on the knowledge, and so they got to bring in people too that are committed and interested, and that's bringing people from all over the place and making sure that information's passed down. So there's that one piece, and then it's also changing the minds of people that are already in the system. And like I know the National Survivors Union in the U.S. does a lot of methadone advocacy, and they've been trying to do more story sharing with clinicians and just like talking about all the barriers that they face to getting access to methadone, and like really appealing to them from that kind of perspective of like we're people and we are trying to stay alive, and this is a treatment that's effective and has been around for a long time, and it's way better for us to be able to access this in a good way than go to the unregulated drug supply. So yeah, I think it's really like there's a lot of different things that need to be happening at the same time, but I think it's, you know, we can do a bunch of research and stuff too, and I am a researcher, and like sometimes that helps, but then there's all this other stuff you need to do too, obviously, as everyone here knows very well. So
Could I say one more brief thing? Sorry.
I'm sorry, but there were more questions, and we only have a few minutes left. So you were, and then the man in the back. So can you please give the mic to?
She gave it
Oh,
to
you
me.
already
I
have it.
have a
Sorry.
very short question.
Okay.
My question is for Mohammad. When you talked about and I know the UDSs are a poor metric for follow-up, but the slight increase in fentanyl use, that was about like 7 months. I was wondering if you guys were accounting for norfentanyl, which is a metabolite of fentanyl that tends to show up when people actually stop using fentanyl and can tend to cause like false. Okay, cool. I was just curious about that. I'm a drug checker from Seattle.
Hello. Hi, my name is Craig Rogers. I'm an addiction medicine specialist from Australia. Don't worry, Anna, I'm not going to ask you any questions. My question's for Mary. We use a lot of buprenorphine in Australia, and it's sort of becoming one of our preferred methods, and mainly depot buprenorphine. However, we do allow people choice, and if they do want methadone, then that's absolutely fine. In your study, did people get precipitated withdrawal when they were doing the microdosing? And other quick question is there any depot bup? Because we find we can give that more or less straight away without withdrawal.
yeah, so we, that's a great question. We had a pretty small amount of people who had reported the microdosing for kind of the information we collected. There were a couple people who said, you know, they had reported they experienced it even while microdosing. So that's one piece. And then for injectable bup, there's some use that's going on in the US. It's kind of building up. And there was one clinician who was in the room earlier who we were just talking about this yesterday about how the 7 days, the 30 days wait, are you talking about injectable bup? Oh, okay, yeah. Okay, yeah. Yeah, and what we've been hearing was that, well, so I guess I will say for a lot of people that go on to injectable bup for like the 30-day long-acting, it a lot of times they get started on sublingual first, and they say, you know, because they don't want to send someone into precipitated withdrawal, but also I had heard that the 7 days is not as much of a concern with precipitated withdrawal, so that's another strategy that people had been.
Because the onset of action is about 12 to 24 hours, depending, I think I was going to be confused. I think the weekly is 24 hours. You can give that almost straight away and generally not get precipitated withdrawal if they don't have anything else in their system like methadone.
Got it.
Yep.
Yeah.
Maybe fentanyl, I don't know. We don't have fentanyl.
At the injecting centre in Melbourne, like my sister service, they've started somewhere between 250 and 300 people on the weekly dose of long-acting injectable buprenorphine that have had heroin that day, and there is no precipitated withdrawal. So it's not correct to say that Suboxone or buprenorphine will inherently cause precipitated withdrawal.
Yeah. I will say by far the large majority of people in where we're studying it's sublingual. The other formulations are not very common. But yeah, thank you for saying that.
Thank you. That was my question, actually, that the dosing was daily dosing in your case, or every other day for the...
For everyone that we did include in this smaller amount, that's all sublingual, and sublingual's very common in the US as opposed to the other formulations, but we're starting to look into that a little bit more too.
Thank you.
Yeah, just a quick comment. The risk of precipitated withdrawal is much greater in countries where the illicit drug's predominantly fentanyl. So that makes a big difference. But if you give enough buprenorphine, they won't have precipitated withdrawal. If you give them 48 milligrams sublingual, they'll be fine. Then you can give them whatever you want as an injection.
Thank you. I think we're starting a very good discussion here, but I'm very conscious of the time, and we have an important next part of the day of the program for you also to maybe get ready and pretty for the party. I just wanted to give you the floor because you had something else to add, and I cut you off. But if you can be short, maybe.
I'll make it very short. When I went to Canada, I turned up like a time traveler asking about a modality that was no longer useful. And people literally communicated how diamorphine had become homeopathic. And so I think I call that out as an imperative to take action. I think it doesn't really matter what it is. It's about engaging people in rewarding treatment that is effective. You know, and respect and dignity is what makes it effective and rewarding. It's kind of a closed circle and pretty straightforward, and it makes an enormous difference. And without exception, diamorphine and injectable treatment, people rolled their eyes. That must have been very irritating. They were kind of like, that's too little, too late. That ship has sailed here. So let's avoid the metastasis of the drug supply and the utility of good treatment engagement with what we have to hand already now.
Thanks very much. Mohammad, you had to add something?
Sorry, one very quick. One more thing about the handprint is that a lot of people don't have IDs or health cards. So like you need something to be able to do. And a point about the clinicians, and we've talked to a lot of clinician prescribers in Canada. I think like there are many champions in the Canadian context that are doing this, but they do get a lot audits unregularly. Like you do get audits if you prescribe opioids, blah, blah. But these people, most of them have told us that they are being targeted by the college, which is not a helpful response by them. So I think like one thing that might help out with these types of interventions is to treat them as what they are. Okay, this is a clinic, like we can have clinical practice guidelines like we did for OAT. I think like when I read the history on methadone, when methadone came along or buprenorphine, like there was opposition to that too, right? It's like with any novel medication coming in, there would be like an established body of prescribers or advocates or whatever that will dismiss it. But I think like if we go with the evidence that has been generated and is being generated, this could be part of the response. And I emphasize that this is part of that response. Thank you.
Thank you very much. I think we're coming to time. Maybe, I don't know if you would like to add something. No? Because we are working also with you, with Ukraine on a pilot of long-acting buprenorphine, which is in the context of war, could also be very interesting, because I think I fully agree, we're talking about different medications, but it is about also service delivery and which forms of delivery are the most effective. And we need all these options, because nobody is the same and people will have different needs and etc. So do you want to say something about the Buvidal? Yeah, exactly. There was and maybe just okay, I'll close.
We had the Buvidal courses in Ukraine. It was like a donation. During the war, we received 500 courses. But unfortunately, there also were research about Buvidal, but it wasn't really high in demand, actually, in Ukraine. And as I know, its shelf life of this medicine ended in January, and even we need to utilize some part of Buvidal. There are lots of myths people, someone scared to receive Buvidal, and one of also we heard that some clients, you know, when you receive Buvidal, you came to healthcare facility once per month or once per 3 weeks. But it's not good for clients, for OAT patients. They want to socialization. And it's also was a reason why they stopped using Buvidal. And it's like, it was in Ukraine, such situation, yes.
Thank you very much. Maybe just to say that WHO is also updating its guidelines on the treatment of opioid dependence and opioid overdose. And they are supposed to come out at the end of the year, maybe early next year. And that includes both medications as well as service delivery options. I just want to thank you all. First of all, the panel members and for really good presentations, very varied, but also very good, and a good discussion with the audience. I think I'm right that there were no questions online. I think it's a bad time for other parts of the world at the moment. So thank you all very much, and well, hope to see you at the party.